Moving on to the third section of our lecture, which is the head injury. Traumatic brain injury is almost always associated with a head injury, and there are various types of fractures uh, involving a frontal, temporal, parietal, or occipital part of the skull. So let's discuss this in detail. In this section, we will talk about skull fractures, the cranial nerve injuries associated with these fractures, and how head injury can lead to seizures. Now, how a skull fracture occurs. Whenever there is a blow to the skull that exceeds the elastic tolerance of the bone, it causes a fracture. Intracranial lesions accompany roughly two-thirds of the skull fractures, and fractures increase the chance of underlying subdural or epidural hematoma or a deep cerebral hemorrhage. These are primarily markers of site and the severity of injury, and they provide potential pathways for entry of bacteria to CSF. If there is underlying arachnoid membrane is torn after a skull fracture, the fractures provide potential pathways to bacteria into the CSF, which can cause meningitis and leakage of CSF, also known as CSF rhinorrhea. If the leakage is severe, it might cause severe orthostatic headache. The patient will experience a headache due to change in position, and it basically occurs after the loss of CSF from the brain. Now, there are several types of skull fractures. We will discuss all of them in detail, one by one. The first one is the basilar skull fractures. These are usually the extensions of adjacent linear fractures over the convexity of skull. They extend from the point of impact toward the base, as we said by the name basilar skull fractures. They may occur independently owing to stresses on floor of the middle cranial fossa or occiput. They are usually parallel to petrous bone or along the sphenoid bone, and they are directed towards sella turcica and ethmoidal groove. Mostly, basilar fractures are uncomplicated, but if they are complicated, they can cause signs such as they can lead to CSF leakage through the nose. They can cause pneumocephalus, that is, air inside the skull cavity. Delayed cavernous carotid fistulas can be formed. There will be hemotympanum, that is blood behind the tympanic membrane. Ecchymosis over mastoid process, which is also known as ecchymosis over mastoid battle sign, or there can be periorbital ecchymosis, also known as raccoon sign. These are diagnosed if we are suspecting these signs and symptoms. We need to get a CT or MRI in order to diagnose these fractures, because routine X-ray examination may fail to disclose the basilar fractures. CSF leakage occurs through the cribriform plate or adjacent sinuses. It causes CSF rhinorrhea, that is leakage of the CSF through the nose. If there is persistent rhinorrhea, it means that the pathway is open and bacteria can enter the skull through that passage, and they can cause a recurrent meningitis. So it requires surgical repair of torn dura underlying the fracture. If we want to determine the site of leak, we have to perform certain diagnostic tests to determine the location of an intermittent leak is infrequently delineated, because many resolve spontaneously. So what are the diagnostic tests? These include installation of water-soluble contrast into CSF followed by CT, injection of radionuclide compounds or fluorescein into CSF, and insertion of absorptive nasal plugins. All these tests are used to determine the site of leak. Moving on to the sellar fractures. Sellar fractures, even those associated with serious neuroendocrine dysfunction, may be radiologically occult, or they might be evident only by an air fluid level in the sphenoid sinus. Fractures of dorsum sella cause sixth or seventh nerve palsies or optic nerve damage. If we talk about the petrous bone fractures, especially those associated along the long axis of bone, they are associated with facial palsy, disruption of ear ossicles, and CSF otorrhea. Transverse petrous fractures are less common. They damage cochlea or labyrinth, and they often involve the facial nerve as well. External bleeding from ear results either from the local abrasion or the petrous bone fracture itself. Now, if we talk about fractures of the frontal bones, these are usually depressed fractures and they involve the frontal and paranasal sinuses and orbits. The patient might present with raccoon sign. There will be debridement and exploration of compound fractures is required in order to avoid infection. Simple fractures do not require surgery. So depressed scalp fractures are typically compound and they may be asymptomatic, but some of them have underlying brain contusions. Moving on to the cranial nerve injuries, the most commonly injured nerves are olfactory, the first cranial nerve, optic, the second, oculomotor, the third cranial nerve, trochlear, fourth, first and second branches of the trigeminal nerve, which is the fifth nerve, and facial and auditory nerves, which is the seventh and the eighth cranial nerve, also known as the vestibulocochlear nerve. If we talk about the olfactory nerve, there will be loss of perception of aromatic flavors in case of olfactory nerve injury, but the taste perception will be retained. In 10% of patients with severe head injuries, especially from falls on back of the head. Displacement of brain and shearing of olfactory nerve fibers occurs coursing, those fibers which are coursing through the cribriform bone, they may be injured, and partial recovery of olfactory and gustatory function is expected in case of an olfactory nerve injury. But if there is bilateral anosmia present in a patient, the prognosis is poor. Partial optic nerve injuries result from close trauma and they cause blurring of vision. There will be central or paracentral scotomas, which are usually the visual field defects. Scotomas is a sector defect in the visual field. Or sector defects involve a nasal or a temporal defect in the visual field. Direct orbital injury causes short-lived blurred vision for close objects. It occurs due to reversible iridoplegia. What is iridoplegia? This is paralysis of the sphincter of iris, which causes short-lived blurred vision for close objects. Moving on to the trochlear nerve injuries, it causes diplopia that is limited only to downward gaze, and it is corrected when the head is tilted away from the side of lesion. It occurs frequently as an isolated problem after minor head injury, but it may develop for unknown reasons after a delay of several days. Facial nerve injuries. Facial nerve injuries are usually associated with basilar fractures. They are present in 3% cases of severe injuries. Facial nerve injuries may be delayed for 5 to 7 days. They may not appear at the time of injury. Fractures through petrous bones can also cause facial nerve injury, but they are less common with the transverse type. They are liable to produce facial palsy, but usually delayed facial palsy occurs after a week of injury. And it has a good prognosis whenever there is a facial nerve palsy due to a petrous bone fracture. Moving on to the vestibulocochlear injuries. These occur from a fracture of petrous bone and they lead to a loss of hearing. vertigo, nystagmus, deafness from the eighth nerve injury. It can also cause dizziness, tinnitus, that is ringing in the ears, and high tone hearing loss. So these all clinical features are associated with the vestibulocochlear nerve injury. So, if we summarize all these nerve injuries, the olfactory nerve results in anosmia and apparent loss of taste. If there is partial optic nerve injury, it leads to blurring of vision, central or paracentral scotomas, and sector defects. Direct orbital injury leads to short lived blurred vision. Trochlear nerve damage causes diplopia, that is limited to downward gaze. Facial nerve injury causes facial palsy. And eighth cranial nerve injury leads to loss of hearing, vertigo, nystagmus immediately after the injury, deafness, dizziness and tinnitus, and high tone hearing loss. Seizures. We say that traumatic brain injuries are associated with seizures in the long run. They are uncommon immediately after a head injury, but there is brief period of tonic extensor posturing and few clonic movements of the limbs occur. They occur just after the moment of impact. There are cortical scars that evolve from contusions and they become highly epileptogenic in with the time and later manifest as seizures. Severity of injury roughly determines the risk of future seizures. 17% of individuals will develop a seizure disorder in the future. The risk is less than 2% or up to 2% after mild injury. And if we talk about penetrating injuries, they have a higher risk of subsequent epilepsy because they damage the brain, cortex of the brain directly. So, this was all about the skull fractures and seizures. Keep watching sqadia.com.